Good evening, ma'am.
Hi, good evening, Saloni. So Dr. Fagun is also joining. He said he has joined and he had some issue and had to join back again.
Hope he has joined through the right link.
Yeah, I cannot join through my PC, that's why. Join through my mobile. Okay.
Everyone, can you rename yourself so that we...
Yeah, can you hear me? Hello.
Yes, ma'am, you are audible. You can just rename yourself, ma'am. It
Yeah,
is
okay.
difficulty.
Yeah.
Good evening, Fagun bhai.
Yeah, good evening. Good evening.
I think, can I change you as a friend? Name. Rename. Can you rename yourself so that we know?
Okay, I'll just
It
hold
is
on.
showing you as an NRF faculty, so we can
Okay,
rename
okay,
it.
okay, okay, okay.
Just then we are good to go. So shall we start?
So just a second, we are still in the practice session. Devarun, is the session
live, ma'am.
I think he said that the session is live.
okay?
So good evening, everyone. Welcome to the NOEL session. Today we are going to have a session on a case presentation on acute kidney injuries and various case scenarios. To discuss this, we have very experienced faculties, and to present the case, we have a Dr. Saloni Sinha. She is a fellow at Surya Hospital, Jaipur. And to moderate session, we have got Dr. Akash Sharma. He is a neonatologist at Surya Hospital, Jaipur. And to as an expert, we have got Dr. Urvi Sanghvi. She is a neonatologist from Anmol Newborn Care Center, Rajkot. And we have pediatric nephrologist, Dr. Fagun Shah, amongst us. Dr. Fagun Shah is a pediatric nephrologist at Child's Kidney Care Center, Surat. So we hope we are going to have a very interesting sessions, and there is a lot of case-based approach and discussions. I request all the attendees to put your questions into the question and answer box, and at the end, if you get time, we'll have a question and answer session. So without much delay, I would like to hand over to Dr. Saloni. Saloni, you're good to go with the session, so please start.
Yes, sir. Thank you very much. Let's start our discussion on neonatal AKI. It's a case-based approach presentation. Let's start with our case number 1. So case number 1 is a male newborn born at 26 weeks of gestation, which with weight of 665 grams via emergency LSAS in view of mother having impending seizures, thus pre-eclampsia, The baby was incubated and kept on SIMB mode on day 1 and was brought to our center on day 5 of postnatal life with a weight of 520 grams on HFO. The baby was started on IV antibiotics in view of risk factors for sepsis and sickness, that is Piptaz and Amica. Feeds were not initiated till now and was completely on TPN, consisting of protein, lipids, and a GIR of 8. Baby was on inotropes in view of cardiac instability, consisting of dopamine and adrenaline, which is low dose. And the patient had AKI with significant weight loss of a cumulative weight loss of 21%. The USG cranium showed medullary vein thrombosis on arrival. When we subjected this patient for RFT, the urea was 220 milligrams per deciliter with hypernatremia and potassium of 6.4 millimoles, chloride of 112 and creat of 1.4. The urine output, which was measured for 24 hours, turned out to be 6 ml per kg per hour. So the question arises here is, how do we diagnose AKI in such neonates? How do we differentiate AKI into pre-renal, intrinsic, or post-renal based on the clinical features in the scenario available? And does this potassium level mandates treatment? Coming to the classification of neonatal AKI, AKI is characterized by increase in the blood concentration of creatinine and nitrogenous waste products, along with the decrease in GFR, and the inability of the kidney to appropriately regulate fluid and electrolyte hemostasis. As per NIDDK classification, we categorize AKI into 4 broad categories, mainly on the change in the serum creatinine value and urine output over 24 hours. So in stage 0, there is no change in creatinine value, or the rise is less than 0.3 mg per dl within 48 hours, or the urine output is still more than 1 ml per kg per hour. In stage 1, the creatinine level rises from 0.3 mg per dl within 48 hours, or the baseline rise is from 150 to 200% from the previously lower value. Sometimes we may not have these values as a baseline creatinine. The urine output here decreases and becomes less than 1 ml per kg per hour. In stage 2, the serum creatinine rises 200 to 300% of the lowest previous value, and the urine output becomes less than 0.5 ml per kg per hour. In stage 3, the serum creat rises more than 300% of the value, or the absolute number reaches 2.5 mg per dl, or the urine output reduces less than 0.3 ml per kg per hour from last 12 hours.
So the case scenario is very common in our neonatology practice, that when we are taking care of 23, 24, 25 weekers, and these neonates have a very dynamic fluid balance. So this is not uncommon that we face neonates who have dehydration and they have some sort of uremia as well as hyperkalemia. So my question to Dr. Fagun sir is that this level of potassium, that is 6.4, would it mandate treatment? And what is non-oliguric hyperkalemia, and how do we approach these potassium levels between 6 to 6.5 or between 6.5 to 7 in these neonates? What do you think, sir?
So coming right from the beginning, you can just go to the previous, the first slide which you presented first of all. So no, the second one. So first of all, I would just like to know that the inotropes are dopamine and adrenaline low dose. I'm just a little bit swaying away from the whatever question you asked. So what is the point in starting dopamine and adrenaline? Because this is a very common thing which I have in discussion with the neonatologist, because you are giving a drug which is causing the positive inotropic activity. So I guess the dopamine is not used here to augment the urine output. And that is, what is the low dose? What dose was the child on?
So this was an outborn newborn. So we don't use dopamine in our unit.
Correct.
And they were using dopamine. And this is another question that we want to discuss, that there is, what we want to convey is that there is no renal dose of dopamine.
Yeah.
There is
So
no
basically-
renoprotective effect of dopamine.
Yes. So basically, if it is a renal dose of dopamine, say for example, 3 to 4 mics per kg, then we are quite justified in having a polyuria in this case. That is number one. Number two is already the child is polyuric and probably it's a 500 gram baby in which there is a lot of tubular dysfunction, and probably the child is also having quite immature kidneys. So basically at this point of time, the polyuria itself is one of the important cause, given the fact that the child might not have been given proper fluid. So polyuria is basically one of the reason why the child is developing AKI, and considering the values of the biochemistry, that is the urea is very high, and if you consider at the 5th day of life, the creatinine level is 1.4, which is quite expected at this age in this age group. So I'm not worried about the creatinine value, but definitely the urea is high. So here it's a very simple case that is basically a pre-renal cause of your dehydration. And as the sodium also says, so that is 157. This is probably because the amount of the urine, the water loss is more of a free water loss as compared to the sodium loss. Now coming to the second point is the potassium, which is 6.4. So again, as I told you, that these are quite immature tubules, and there is of course no activity of the aldosterone on the tubules, that is on the collecting ducts and also on the distal tubules. So as a result of this, basically this child will have a high potassium level, which could be a normal level for about this age group. So for example, if you consider a term child, we can consider 5.5 to 6 as normal. We are not much worried. Similarly, for this child also, say 6, 6.4, 6.5 could be okay. And most of the times we will just observe to wait. Even if it is 6.5, then the routine hyperkalemic measures which we use, that is nebulization, etc., will be more than enough. But the most important thing is that as far as the description of the, what we say, your the
case.
definition, or what we can, I mean, just go one slide back. The classification. So the classification. Yeah. So I think what we are using is basically the KDIGO classification, which is 2012 classification, which takes into consideration urine output and the change of serum creatinine. And this is the only reason why change of urine output is also placed over here. This is because that many a times the serum creatinine is basically a very poor marker actually of the creatinine clearance or the GFR. And in fact, the creatinine lags behind at least 36 to 48 hours. So what creatinine you might be seeing may be a 48-hour old creatinine, and that's why sometimes we are misguided. So it is for this reason that we take into consideration the urine output. But as far as the urine output is concerned, I think so we don't wait for 24 hours. In the NICUs, especially in this small child, we do hourly monitoring. So even in stage 1, it is less than 0.5. That is what KDIGO mentions. It is less than 0.5 ml per kg per hour for 6 to 12 hours. If it is less than 0.5 ml per kg per hour for more than 12 hours, it is stage 2. And if it is less than 0.3 ml per kg per hour for more than 12 hours, it is stage 3. Sorry, for 24 hours, it is stage 3. Or if the child is anuric for 12 hours, it is stage 3. So we don't wait for 24 hours to label the child. We have to act very fast, because the more faster you act, the chances that you can prevent the child from going into a failure from injury, because there are a lot of consequences later on for this renal dysfunction. And coming to the non-oliguric hyperkalemia, that is basically hyperkalemia in which the potassium levels are high without any what we say, a decrease in the urine output. So basically we all know that with AKI we have a hyperkalemia because of the decreased function of the kidneys. But here, as we have as I just told, that the patient might have a resistance to the action of the aldosterone because of the immaturity of the tubules, and as a result of this there could be hyperkalemia. The patient is sick, newborn, there are a lot of cell turnover which can also lead to the cell lysis and hyperkalemia. The hyperkalemia can be because we might not know, there could be a beginning of something like an hypoaldosteronism or a CH, etc. That is a congenital adrenal hyperplasia. So all these things has to be kept in mind. But here at this point of time, I will not be much worried about this level of potassium, considering the fact that it is a very, it's a extremely low birth weight baby with a significant immaturity of the tubules.
So the point we would like to address for budding neonatologists is that what the primary neonatologist was getting confused in was uremia, and they were actually trying to restrict fluids because they thought that this is AKI, this is going in AKI stage 2, stage 3. Simultaneously, they were not giving enough pre-water. They were actually giving protein of 3.5 gram per kg. That was actually resulting in excess uremia, and they were not giving enough fluids. They were not monitoring the urine output. And as I said, that urine output should be monitored, as I said, hourly, but we usually do it in every 6 hours, and our titration for fluids is based on every 12 hours we change in extreme terms. So point well taken, sir. And we move ahead in the case now.
So the uremia here in this patient, along with the AKI, was attributed to dehydration, that is pre-renal AKI, likely due to the sensible water loss and also due to the aminovein that patient was receiving. So here, in this case, we decreased the aminovein to 1.5 mg per kg and relaxed the fluid. Whatever urine output was beyond 4 ml per kg per hour, we replaced it with N by 2 plus N by 2, and the total fluid rate was reaching approximately 220 to 230 ml per kg per day. When we are talking about the fluid management in extremely low birth weight babies, there is a very delicate balance that we have to strike between restricting fluid versus liberalizing fluid. As whenever we talk about restricting fluid, the elgans are always at the risk of developing metabolic acidosis, hypernatremia, and dehydration. While wherever we are trying to liberalize the fluid, we are always worried that what if the PDA opens up, or the child might land up into NEC, or be diagnosed IVH because of liberalizing the fluids. So here in our unit, we follow a protocol of titrating as per the changes in the weight, serum sodium, and urine output. So the change in the weight due to the lack of postnatal losses or gain, it is very good indicator of whether we need to titrate, like we need to increase or decrease the fluid. Similarly, the serum sodium, it is predominantly affected by the water intake. So we also take that into consideration, and urine output. In our unit, anything beyond 4 ml per kg per hour, we replace. If the higher levels are there, we definitely replace these losses.
So what is important is that prevention is always better than cure. So preventing insensible water losses will always be better than replacing fluids. So the unit protocol, as a uniformity, we do try to check weights every day. If the child is very sick or very preterm, or we suspect that there are increased sensible or insensible losses, we can actually do it twice a day also. If you have an arterial line, it is easy to get sodium levels. You have to monitor urine outputs. So if urine output is less, weight loss is excessive, you have to titrate the fluid every 12 hours, you have to relax fluids. But say if the weight loss is not as expected, the child is not losing beyond 1% weight daily, and the urine output is more than 3 ml per kg per hour, or the sodium is less, then you need not escalate fluid. Then maybe this child does not require that much fluid. Again, as Saloni said, that there is a very delicate balance in this. Saloni, you can go ahead.
Yeah, just I would like to chip in at this point.
Sir.
The only issue is regarding the doing weight of the newborns, because I just raised this point in many of the neonatal day discussions, and that the weight gain and weight loss is very, very important to be monitored, because eventually in a patient with an AKI, your fluid overload is a very important predictor of the mortality. So basically, most of the neonatologists, because of such babies which are actually on ventilation, they say that it is not possible to weigh the babies in twice a day. So I just wanted to ask you that you said that you weigh the babies twice a day. So how is it possible? Is there any method you have?
So if the child is an Elgan, the child is usually in an incubator, and luckily we have those incubators where we can weigh the child inside only.
Great.
Second thing is, if it is a term child, sir, with AKI, even though if the child is ventilated, what we try is that two staff in presence of a doctor has to weigh the child. They can disconnect and they weigh the child, connect them immediately. And we take the paraphernalia into account as well, because if the child has cannula, PD catheter in situ, so that weight we account, and we account for changes in weight then, and we titrate. As you said, it is very important that we weigh the child.
Yeah, I think that is a very nice point, and I think so everybody, because as I told you in all the discussion with the neonatologists, they just come up with this excuse. But I think so that you cleared the point very nicely, and I think so that you must also discuss in your forum that the weighing of the child is very, very important twice a day, especially the child with the AKI, because we can know what is the degree of the fluid overload, and this helps in making important decisions actually.
Agreed, sir. So the another contentious issue is that, as I said, prevention is always better than cure, but somehow our sensible and insensible water losses can be there, because every unit may not have an incubator. Or in fact, if we have two incubators, but there's a third child who requires an incubator, he'll be in an open care. We are always worried about PDA and BPD. Whenever we relax fluids, we have always been told in our traditional teaching that you have to restrict fluids in PDA, restrict fluids, or else the child will develop BPD. So here the child received at least 220 to 240 ml per kg per day fluids. He is an Elgan who had a weight of 520, 550 grams. So Dr. Urvi ma'am, what do you think that such PDAs, as we can see on the echoes, should we actually increase fluids, or should we risk the child that let him land up in some form of uremia, but we maybe maintain a fluid up till 150 to 180? What is your take, ma'am?
Yeah, as per the latest guidelines, if we see that if it's not a hemodynamically significant PDA and already child is now fifth, or say if we see the previous slides that fifth to seventh day has arrived of the child, so we can give the maintenance fluids, and as we see, we have to see the urine output. Like if the diuretic phase is happening, we cannot go for further restriction of the fluid, because that again will hamper with the nutrition of the child. So in a hemodynamically significant PDA, again there also, if we are seeing that if the urine output is maintained and the child is getting adequate nutrition, we can give the maintenance fluid, say up to 180 also, if we can monitor the other parameters along with this. So there is not a, now the concept of restricting fluid is not there. Unless the child is retaining fluid, as you say, you are checking the weight of the child daily. Plus, we see the flow in the IVC also, and also the renal flows, that if the duct itself is causing some hampering in the renal flows, those also we have to see with the bedside ultrasound. So restricting fluid in PDA is not a concept anymore. In fact, in last just 27th October 2025, one article is published in this pediatric research. So this is very good. They have done all retrospective analysis of past they have taken two cohorts in which 2018 to 21, one cohort is taken in which fluid restriction, that concept was there. And then 21 to 23, one cohort is taken in which the fluid restriction is not there. And it is very nicely been analyzed, and they have said that we should look after the nutrition of the child, and the flows obviously we see by the echo. We have to keep on doing that to see that the child's as such hemodynamics is not disturbed by restricting the fluid, and nutrition is not disturbed. We have to give the proper fluid. So main thing is the growth of the child in this baby.
So 2 points to take away from this discussion for the fellows is that first, restricting fluids is always not necessary. It depends on the individualized clinical as well as hemodynamic parameters of the child. So as ma'am said, there is a physiological study from 2013 that said that if you restrict fluids in a case of PDA, already the diastolic flow is a little less, the pulse pressure is more. So actually by restricting, you are actually stealing the diastolic blood also from the end organs. So this study has been referenced all over. So you need not restrict. It depends on the hemodynamic status, as ma'am said. So in fact, if the sensible losses are very large, you have to replace. So urine output replacement has to be done by N/2 and add potassium in that.
Yes,
Yes.
and weight obviously we are doing of the baby, so
Yeah.
that it's also so if there is weight gain in a hemodynamic significant PDA, yes, that's a red flag we have to be considering.
Sure. Go ahead, Salwa.
So even I think in BPD, if we see, I think that point is also there. Even if
Yeah.
we have to take care of the nutrition, not be thinking of the fluid restriction. Yes, we don't go for the boluses, or in the first 3 days, we don't overload with fluid, because that's for the duct. But the maintenance fluid, which has been clearly defined by the guidelines and protocols, should be given to these babies. Because as more nutrition we take care of these babies with the proteins, with the carbohydrates and lipids, that itself will help in the growth of the alveoli and everything, and will prevent BPD.
Agreed.
This case, day 6 of USG cranium showed urinary vein thrombosis. On day 12, the patient had weight of 600 grams, which the USG cranium was repeated, which showed cystic degeneration of lateral most part of parietal occipital lobe, and the urine output started decreasing subsequently. The AKI resolved, and here we would like to discuss the topic of free water deficit along with the solute fluid deficit.
No. So, you can go to the previous slide. So in this case, just by managing fluids well, the AKI resolved. So there are two things, that there are some nephrotoxic medications that are simultaneously ongoing. That includes antibiotics, that can include diuretics also. And here there's a neurological insult. So despite that, luckily this child is actually doing well. He had BPD, was at home oxygen for 6 months, but is currently now 6 kgs in weight and completed his birthday last Diwali, and doing well even on home oxygen. So I guess we can take questions and some discussion on this topic. So ma'am, any suggestions? Jatin sir, Gunjana, Urvi ma'am, and Fagun sir.
Just I would like to highlight that what here you, as you have already told, that fluid management in the initial days, there should not cause dehydration. So this is all more because of that extremely low birth weight baby going into dehydration and causing pre-renal failure.
So fluid management has to be optimized for LGANs. Majority of AKI would result from either there is a multiple components that can include pre-renal sepsis, nephrotoxic medications, and there is a hesitancy to give fluid, and the majority of the units won't monitor urine output stringently. I think that is the key takeaway, that majority of LGANs would may go down this course, and CNS insult that we want to prevent, actually dehydration is causing that insult in itself. So that has to be taken care of. Hypernatremia in this case will automatically resolve once once you give free water, and once you are replacing the urine output. I guess the next slide is just based on hypernatremia, where we can discuss how even on term newborns in hypernatremia, what is the concept of free water deficit and solute fluid deficit. Fagun sir or would be ma'am, whatever you can tell them, because it is a very common scenario, especially in hot arid regions, and majority of fellows will find it hard to actually conceptualize how to replace fluids in cases of hypernatremia. This is just going offshoot for term newborns with hypernatremia. If they are dehydrated, having hypernatremia, what should we be looking at once we are replacing these fluids?
See, actually, as far as you rightly mentioned, that in hot regions, even in Surat, we get a lot of patients, especially in the month of April, May, who come down with their term infants and the term neonates, especially to the mothers who are having, who are delivered by cesarean section, in which the mothers don't give proper feeding for the first 2-3 days. They just come up with decreased feeding, and once we do and severe dehydration, there is a loss of weight of about 15, 20, 25% up to the level of 25%. And just we do a serum sodium, we just get a level of about 180, 190. Now, actually, there are a lot of definitions for this. It's not a simple one definition, and you can just go through the text and you can find on the net everywhere a lot of definitions. So whatever you do, but basically one important thing is that here, that most of the times the loss which is occurring is because from the increased surface area. That is basically it is the evaporative loss which is occurring. And most of this losses, there is a loss of sodium and fluid as well. But the amount of fluid loss exceeds that of the sodium loss, causing a condition in which the amount of sodium in the blood increases. So this hypernatremia has a lot of implications, because sudden rise in the sodium level can definitely lead to your pontine myelolysis, as well as it can also lead to the intracerebral hemorrhage, etc. On the other hand, it can also directly lead to the kidney injury, and the patient can come up with the high creatinine values with the dyselectrolytemia and other issues. So most of the times we need to correct not only the free water, that is giving a simple plain water, but in addition to this, we also need to give sodium for the maintenance, because the total body water sodium is always okay. This is just basically a reason, or we can just simply set an example that there is a glass of water in which we have kept 2 teaspoons of salt, and suppose if that water becomes half, in that conditions the sodium concentration will increase, though the total body sodium is okay. So this is the condition which is occurring over here. So you need not only to correct the free water deficit, that is to give free water, but in addition to this, you have to give the normal sodium also, because if you just give free water, there will be a sudden drop in the sodium, which we don't want. We ideally want a drop of sodium not 10 milliequivalents per 24 hours. That is it. So you say, for example, the child is coming with a sodium of 190. I don't want to correct it in the first 24 to 48 hours. I'm not worried about the 190 sodium. I just want that the sodium should fall by about 8 to 10 milliequivalents per day, so that by 4th or 5th day, I get a normal sodium. And most of this times, this child is quite dehydrated. So you need to calculate the fluid, because the fluid which will be required will be the amount of the fluid which is a free water loss, as well as the solute loss which is occurring, and the normal requirement. So all these things has to be categorized, and you can put it in the formula, because there are a lot of formulas available. I use a different formula. So that is it. But the only take home thing is that you need to correct the free water. You have to give sodium in this child. Doesn't mean that 190 you can't give sodium, and you need to correct the dehydration as well, considering both the free water as well as the solute fluid deficit, and correct it over 3 to 4 days depending upon whatever is your sodium level. But the correction of the sodium should not exceed more than 8 to 10 milliequivalents per day.
Along with this, sugar and glucose maintenance also
Yeah.
should be added in the fluids which we are giving. That's just what I want to add. Otherwise, I think Dr. Fagun has summarized well.
So I think the majority of fellows or early MD or DCA students, they find it counterintuitive when a child comes dehydrated and he is hypernatremic. Actually, you have to give NS N/2. You cannot give hypotonic fluids. At times, we actually have to mix 3% NS and NS depending on the level of sodium. So this is the key takeaway, that you have to give sodium adequate to the deficit. And I think well summarized, sir. So a detailed discussion can be found in many books. Harriet Lane has different formulas. Avery, Fenroff, there are many books which describe what has to be done.
This is just by experience that
Yeah.
for the residents, that if it takes time to calculate the formulas, then most of the times what you can do is that if the level is more than 170, 175, most of the times simple saline will work. And if it is less than about 170, 175, then N/2 will work. You can just monitor the sodium level in the next 4 to 6 hours and see for the drop. If the drop is adequate, it's fine. If the drop is very fast, in that case, you know that you require
Absolutely.
a higher
Okay,
concentration.
Hmm.
And if the drop is slow, then in that case, you require a lower concentration of sodium fluid.
So usually what
Saloni,
we
you
do is
can-
we give the maintenance fluid, has to be given, which is normal electrolytes of base requirement. Additional whatever we have to compensate. In that we add the 3% NS or weather-free water. Accordingly we decide.
Go ahead, Saloni, go ahead. So I guess this is just a brief recapitulation that Awaken study said that neonates had an incidence of AKI of almost 30%. And we could have missed almost 1/3 AKI if we were not measuring urine output. And AKI the incidence is very high in extreme preterms, which you can see 20 to 29 weeks. Even in term newborns, almost 37% of them has AKI. This is because of sickness. Again, because these newborns may have had sepsis, may have had asphyxia. So the burden is huge. And the numbers of CKD would almost nearly to, again, 30%, 20 to 30% of them may go ahead and have CKD. Go ahead, Saloni, we can move to the second case.
So our second case is a male newborn at 38 weeks of gestation via vaginal delivery. The baby was discharged at day 3 of postnatal life on breastfeeding, presented to us on day 14 of postnatal life with significant weight loss of approximately 21%. The baby was severely dehydrated, had lethargy and jaundice. The random blood sugar, which was measured at the time of admission, was 85 mg per dl. The baby was intubated in view of lethargy and ventricular tachycardia, and these were the vitals on presentation. Subsequently, the BBG which was done on arrival showed pH of 7.02 with bicarb of 8, lactate of 6, potassium of 8.2, and sodium of 105. So the patient had acidosis along with hyperkalemia and hyponatremia. The renal function tests which were done on the arrival showed hypernatremia with hyperkalemia with serum creatinine of 1.4. The urine output, which was measured over 24 hours, was 1.8 ml per kg per hour, and the eGFR was calculated to be 11.1 ml per minute per 1.73 meters square. So in this patient, we were dealing with life-threatening hyperkalemia along with ventricular tachycardia with hyponatremia along with AKI as serum creatinine was deranged. Which brings us to the management of hyperkalemia. So when it comes to hyperkalemia, first of all, we stop the potassium-containing fluid if there is any. We stop the drug which accentuates hyperkalemia like spironolactone or beta-agonist. Then we monitor the ECG of the patient. As per the levels of serum potassium, it can be divided into mild, moderate, and severe. The mild serum potassium is 5.5 to 6.5. In such patients, we will see a peaked T waves with prolonged PR interval. When the potassium levels is moderately high, that is 6.5 to 8 milliequivalent per liter, we will see there is going to be a loss of P wave with prolonged QRS interval. ST segment is going to be elevated and the patient might have skipped beats or ectopic beats. In severe cases of hyperkalemia, the ECG is going to be bizarre and the loss of QRX complex is going to be there. It is going to be progressively widened with sine wave and ventricular fibrillation along with asystole is going to be there. So in case of hyperkalemia, we have an algorithm by which we go through whenever we have a patient who has symptomatic hyperkalemia. So if a patient has serum potassium of 6 milligauss per liter or a premature with 6.5, we'll subject the baby to an ECG. If there are ECG changes present, first of all, we are going to stabilize the cardiac membrane by giving calcium gluconate 10%, 0.5 to 1 milliliter per kg, IV over 5 minutes. The duration of action is going to be till 30 to 60 minutes. However, if ECG is normal, we will go for salbutamol nebulization. The nebulized salbutamol is to be given approximately 400 microgram, and there are in text there are mentioning of 4 to 5 microgram per kg of IV, but in our unit we barely use it. We will repeat the serum potassium level if there is no improvement, but the ABG shows metabolic acidosis. We will go for soda bicarb, that is 1 milliequivalent per kg IV, which is diluted into 1:4 with water. Slowly it is given. But if no metabolic acidosis is there and the patient has good urine output, we will go for Lasix, that is 1 mg per kg IV. If there is no acidosis and the soda bicarb has no improvement in the metabolic acidosis, we'll certainly go with insulin, that is 0.1 to 0.5 unit per kg per hour IV, mixed in the glucose, that is 0.5 to 1 gram per kg per hour, and we give it 5 to 10 ml per kg per hour of glucose, that is 10%. If still there is no improvement, we can consider potassium binders, which are non-specific polymeric exchange resins like sodium and calcium polystyrene sulfonate, or only in term infants. In preterm, we do not use potassium binders, and if the patient is going into kidney failure, we consider dialysis. So in this patient, the patient was discharged and was readmitted with us on day 40 with significant weight loss, lethargy, and jaundice, along with ventricular tachycardia. So patient had hyperkalemia and which persisted despite corrective medical measures. So here
this brings to the question that does this child has only hyperkalemia as a primary modality, or does this child has AKI also? Because as you've seen that predominantly he has hyperkalemia with hyponatremia. However, he has some deranged renal functions also. Go ahead, Saloni. So to define AKI, we actually in every newborn that is suspected to have AKI, there is something that we calculate, and in our residency also we have been taught that you have to calculate what is the estimated GFR. Serum creatinine is not a very perfect marker, as Fagun sir already had mentioned. So there's this Schwartz formula. We use Schwartz formula in these neonates. So for term newborns, it is easy to measure the length and therefore calculate this eGFR. In preterm newborns or extremely low birth weight neonates, majority of them won't have a length measurement. So what we try and do is, if the child is appropriate for gestational age, we take the median of the length on Fenton's chart as a surrogate to calculate eGFR. You can go back. Yeah, please, sir. Please go back, Saloni.
Yeah, just go back one slide. So I will just keep the slide of this thing of the Schwartz formula. Yeah. So this is basically the bedside formula, and in pediatric patients we have very little formulas. So this is one of them. If you go for the adults, there are a lot of there's a list of the formulas. Now I just want to correct everybody over here. The most important thing is that, as you all know, that the physiology of the kidney development. The kidney is formed at around 12 weeks of gestation. After 20, and after that, it is just the maturation of the nephrons, which is maximum in the last trimester. So if you come down to the GFR at birth, it is about just 5 to 10, which might increase to about 20 to 30 at 1 week, 50 at about 1 month, 70 at about 3 months, and it takes 2 years to attain the adult GFR of 120 to 125 ml per kg per 1.73 meters square. Taking this into consideration, the Schwartz formula is only in the condition when you have your GFR matured, that is your tubules which are matured, or your glomerular or nephrons are matured. So for all practical purposes, the Schwartz formula cannot be used for children below 2 years of age. It is to be used between 2 to 18 years of age only. Beyond 18 years, again, you have to go for the adult formulas, because eventually it depends upon creatinine, which is the product of the muscle metabolism. And hence, ultimately, your preterm child will end up into an overestimation of the GFR. So what Schwarz has also done is that he has taken the gold standard inulin to know the GFRs of these preterms. So we have the normograms, or we have the values of the GFRs calculated by inulin. That is a measured GFR. This is an estimated GFR, eGFR. One is the measured GFR, which is measured by a renal clearance values. So inulin is the gold standard, which is used, though it is obsolete nowadays. Now they are using ioxol, or they are using other GFR markers, but inulin was the gold standard, and that was used, and the normogram was made. And most of the times when you want to know the GFR of the newborns, you have to divide, you have to calculate this by the Schwartz formula, of course, but you just need to see or match it against the normative values which are calculated by the inulin clearance. So if it is less than one standard deviation, we consider that it is not a risk. Between -1 to -2 standard deviations, it is basically a moderate risk, or we can say a moderate AKI. And if it is more than 2 standard deviation, then it is a severe AKI. So actually speaking, the eGFRs cannot be extrapolated in the newborns, whatever age, even in the term newborns. So how can we escape this? So nowadays, the cystatin C is also coming into picture. And the most important fact about cystatin C is that, first of all, it doesn't cross the placental barrier. So in the first 3 days, as we say, that the creatinine reflexes the mother's creatinine, that is not with the cystatin C. Though because of the physiological low GFR, the cystatin C levels may be higher, but it falls very fast up to 3 months of age, more faster as compared to creatinine. And by 1 year, it can measure, or it can come up to the level of the adult value. Okay. So what you can do is that the other option is that in the younger children, I'm not talking about these preterms, because here it's still basically you can't calculate any of this, but in the younger children, you can use the CKID formulas, which is just a formula in which you have to use the calculator, in which there is a cystatin C based formula. So you can use this and you can get a good GFR just at 1 year of age. That is the only thing which we could do at this point of time. So modified Schwartz formula cannot be extrapolated for the terms or preterms. You have to, there are normative charts, so you have to compare with the normative charts and just see that how much standard deviation it is, and then you can say that whether the AKI is mild, moderate, or severe, or the GFR is
So
mild.
duly taken, sir. So the another point is that the utility of eGFR for neonatologists is not in defining AKI, but rather in changing the dosages of medication.
So that also you
as
can
you
do.
said, I know, sir. So automatically what has happened is, as you said, that 23 to 29 weekers, the antibiotic dosages are different from term newborns. And
Correct.
that dosage is different because the eGFR is low in these neonates.
Correct.
Therefore, they are at every give amikacin every 36 or 48 hours, because we know that it is not going to eliminate. Second, if the child has AKI and is on, say, dialysis, then we don't have any option in how do we change the antibiotic duration.
There is no answer to that, actually.
There is no way. There is no real answer. So we had a question in the end.
Yeah, ultimately what you need to do in an ideal setup is that you have to check the drug levels, which is not possible over here.
Yes. So we take a calculated guess from this.
Yeah, you have to give the. I know, I do agree, and we also do a eGFR by Schwartz only to calculate the drug formulas. But this is the real fact which which is
agreed,
all
sir.
the residents need to know. So that's why I'm telling you.
We need to see the renal perfusion also. We need to checking the perfusion of the kidneys if they are going in the oliguric phase. So that also helps in early clinical diagnosis that AKI has started or what, along with this formulas.
Yes. Saloni, go ahead. Yes. So this is just again, it is a pediatric table. You can go back. So your drug modification is based on GFR, but a GFR of 10 or less than 10 can be normal for a extremely low birth weight or LGAN. Yeah, go ahead. So then there is something called fractionalization of sodium. Again, this is a very dubious kind of a thing for neonates because the concentrating capacity or reabsorptive capacity of a neonatal tubule is very less. So to define pre-renal or renal can be faulty. And this is depicted in the previous case as well, because that child had natriuresis. and urine output of almost 6 to 7 or 8 ml per kg per hour. So his urine sodium might be high, but it is not an intrinsic renal failure. He had pre-renal failure. So therefore, you need to consider all things holistically, that the concentrating capacity of a term newborn is different from a preterm newborn, and fractional restriction of sodium is not a perfect marker of differentiating between pre-renal and renal AKI.
Akash, I will just like to chip in here also. So now, actually, the AWARE studies and the AWAKEN study, which are the largest studies basically for the AKIs, the AWAKEN studies for the neonates and the AWARE studies for the older children. And now what they have told is that you need to take into consideration the renal angina index, RAI. So this renal angina index depends upon two things. It depends upon, one is basically the risk and second is the injury. The risk means either it's a what we say score of 1, 3 or 5. So 1 is basically when the child is admitted in the ICU, so it's a moderate risk. Second is whenever there is some organ transplantation is done, so it is a high risk. And very high risk means the child is on ventilator and has just at least one inotrope going on. So this is renal, this is risk. As far as the injury is concerned, there are 4 points. One, and that depends upon what is your creatinine clearance, and second is fluid overload. So fluid overload less than 5%, 5 to 10%, 10 to 20%, more than 20%, and they are given the scores 1, 2, 4, and 8. And same thing, the creatinine clearance, that is normal 20 less than it is increased to more than 25%, 25 to 50%, and more than 50% is the loss. So if we can extrapolate this even in the newborns, in that instance we can know a score. Say for example, here the score of above 8, we have to just multiply these two things, and a score of above 8 highly suggests that the child is going to develop an AKI, number 1, and number 2, the course in the ICU is going to be very stormy with a direct prediction of the mortality in this case. Okay, so I think so that you as a neonatologist, or even in the ICUs, I go on telling that you start using this renal angina index, because it gives a very high it is a very high sensitivity to predict which children is going to go into the renal failure and how is the prognosis going to be, or how the child is going to behave in the couple of forthcoming days. Okay.
So what sir said is that AWAKEN actually has more than 10 publications. So whoever is interested in reading about neonatal AKI, it is a very good collaboration, consortium. So STAR score is also one of the scores that has come from that. And Dr. Sanjay Wazir and the other people who were a part of that. So STAR score is again similar to what sir says, that you can actually look at which neonates are at risk for AKI and then go ahead from there. So you can go and read about AWAKEN and STAR score and renal angina index. Yeah. Go ahead, Salman.
So in our patient, the patient had refractory hyperkalemia despite of the medical management. So here we turn our head to dialysis. In this patient, the patient had persistent hyperkalemia despite of medical management, so that we went for PD. There are some indications which I've mentioned here.
It's okay. I'll brief it. So what happens is that whenever our students look at any AKI, so they are not very clear when to dialyze. And so what you see here is that anything which is refractory to medical management, in terms of hyperkalemia, in terms of metabolic acidosis, in terms of sodium disbalance, whether it is hypo or hypernatremia, and in fact refractory volume overload, if you are not able to manage by your medical management, judicious medical management, then you have to go for a PD. Only relative indication being that inability to provide adequate nutrition. I don't think I have done a PD for that ever. Our PDs have always been because of the above indications, where either fluid overload is we are not able to manage, the child has oliguria, and even after restricting fluids to say 30 to 40 ml per kg per day, we are not able to manage that neonate there. You can go ahead, sir. Fagun sir, next slide. So what do you think, sir? Do you differ in indications of PD? What catheter to insert? And
actually, I will tell a very practical point actually. So if we take into considerations, to be more simpler, if we take into consideration the indications of PD, I will divide it into 2 parts. Number 1 is basically the clinical indications, and number 2 are the biochemical indications. So the clinical indications are always most important. The biochemical indications, many of the times we could manage. So what are the clinical indications? The most common indication in the neonate is basically fluid overload. That is the most common indication, because we have, we don't have the the liberality to use the fluids as far as the neonates are concerned. And many times we need to give the blood products, we need to give the IV fluids, we need to give antibiotics, etc. So all these things causes a lot of chaos, and ultimately you land up the child into severe fluid overload. And I will just tell you that once the fluid overload goes above 10%, the mortality is in the tune of about 40 to 60%. And above and about 20-25%, it is almost say 70 to 80% mortality. So basically, for neonates, the most common indication is basically fluid overload. Definitely the signs of uremia, which we don't find out, which is very difficult to delineate in the patients who are neonates. Say, for example, the child is having encephalopathy or convulsions or uremic bleed, because these child are having sepsis, they are having low platelets, they are having bleeding tendencies. So we cannot differentiate other things. But the most important thing is fluid overload. Hyperkalemia, most of the times it is easy to manage by medicines. And also hypo or hypernatremia. Again, one important indication is severe metabolic acidosis, because we go on giving then soda bicarb and eventually land up with the hypernatremia, which is eventually again causing the AKI. So I think so these are the two most common indications for which we practically do PD in our neonates in every setup. I think so, because this is the most common indication. So coming to this now, how do we manage this? So eventually, as
You
far
can move
as
ahead, Saloni. Sir, please go ahead. Move the
yeah,
slides to catheters.
yeah.
Yeah.
So basically, what I personally prefer, definitely there is a lot of discussion and debate about whether to use diuretics, whether to use dopamine, whether to use phenoldiazepam, whether to use any other things which is causing diuresis. Theoretically speaking, definitely this is just going to increase the renal blood flow. It is not going to improve the GFR. So eventually the long-term or short-term consequences in getting normal GFR or normal creatinine is not going to happen with this dopamine or phenoldiazepam or etc. Okay, that is number one. Number two, it is not a modality to treat, that is the phenoldiazepam or this thing is not a modality to treat the AKI. It is not going to cause the creatinine to come down. And the long-term consequences, say for example, development of the CKD in the later age also is not going to change. So practically speaking or theoretically speaking, definitely these drugs don't have any much value in improving the GFR. But as I told you, practically, renal blood flow definitely increases. I have seen in my practical personal experience, combining a low dose Lasix infusion, 0.5 to 0.05 to 0.1 milligram per kg, and a low dose dopamine, 60 to 70 or even 80% of the times the child starts pouring in 12 to 24 hours. And as I told you, our main concern is giving fluids and main concern is fluid overload. So we easily get rid of it. Ultimately, AKI to theek hone hi wala. It is going to get cured. I mean, the response is going to be there. So practically speaking, if we want to treat the AKI or want to decrease the fluid overload, because we all know that inserting a PD catheter and doing a PD for 48-72 hours in a neonate of 1 kg is very, very challenging. We get a lot of calls for the what we say mechanical obstruction of the PD catheter, PD line, momentum getting stuck to it, momentum coming out, and all these practical points. So mechanically, it becomes very challenging to do a PD. It is not as easy as hemodialysis ke humne 4 घंटे कर लिया and we are all out of it. So it is not that. PD is very, very challenging and very, very demanding in the case of a neonate. So as far as possible, practically speaking, what I would like to do is I will try to convert an oliguric renal failure into a non-oliguric renal failure, given the point that other biochemical parameters could be managed by these drugs. If not, eventually we have to go for PD. And for PD, there are a lot of other catheters, Tankov catheters, and as I told, and the what we say that the single this thing, the Tankov catheters, the pigtail catheters. Even we have this. Single cuff and double cuff catheters, but practically speaking, it is very, very difficult to insert in a 1.5 2 kg child. So normally what we do in our NICUs or wherever I go for doing a PD is that we use a simple Romson trocar cath. This trocar cath, we use two numbers. One is number 10 and number 12. Less than 1 kg or 800 grams, put number 10. More than 1 kg, put number 12. It works fantastically. You might need to create some extra holes, which you can do mechanically and just start doing it. So I think this can last at least for 4 or 5 days if it functions nicely. Otherwise, the stiff catheters are very, very dangerous. I had an experience of perforating the intestines in patients in which stiff catheters were put. So I use these catheters. I think they are nicely, I mean, the photos are given over here. So these catheters are practically which we normally put in our units, in the units where I go rather.
I
So
would
we
like to
have moved
ask,
away from, yeah, please, ma'am, go ahead.
yeah, one question to Dr. Fagun. You said drugs. So, do you think this caffeine aminophylline, we usually start
Yes.
only caffeine in newborns
Yes, the
because
AWAKE
of,
study, the AWAKEN study
yeah, that has
seen
shown
that,
that it helps. So, I would
yeah, in
like to know.
25% of the patients. So in patients, but these are the drugs which will help more in the patients with HIE. Okay, the caffeine
Okay.
and aminophylline or deriphyllin or whatever aminophylline, these are drugs definitely mentioned to increase the augment the urine output, and these drugs definitely will also improve the GFR. So, but I don't have. Apart from
So
this, nobody has done a deep study or actually
No,
a
because
prospective
caffeine
study.
regularly we use in extremely low birth
Yeah.
weight. Usually we use caffeine regularly.
Yes.
So
So
that
maybe
helps a
you
lot
might
in,
get some protection against AKI. I mean, you have to
yes.
do some study and then tell us about
But
it.
the takeaway is, sir, that caffeine should not be given for a established AKI to increase perfusion. As ma'am said, theophylline, there are 4 studies. One of it is from Kashmir. So they say that you can prevent AKI and asphyxiated neonates by
Correct.
giving theophylline. But again, it is prevention. Once it is established,
You
there is
can
no role of increasing perfusion with that. And third, I would differ because of using dopamine, because all neonatologists, in fact, don't like
They're
dopamine
scared of
as such in
dopamine.
our
I also
units.
don't like dopamine. It
So
is out of the date.
I
What I
know.
say is,
Yeah.
Yes, yes.
I say
So
that
yeah.
it's a
So
very
our
low dose.
experience, yeah. Sure.
Yeah, it is a very small
Sure.
dose. I mean, never I prescribe more than 3 to 4 miles, which is not going to cause any sort of inotropic effect on your heart rate.
We have moved away from SIP catheters. What we use is these are Vigon ICDs,
Yes.
which, as I said, additional holes, very easy to put in, minimal trauma, very flexible, and they work well. In fact, in very extremely low birth weight neonates, one of them we have used a 20 gauge cannula as well. But again, these are 500, 600 grammars, and we do it only in extreme circumstances.
Yes.
Go ahead, Saloni. Go ahead.
Exactly. In a extremely preterm or extremely low birth weight, doing a PD is itself a challenge because of the skin and infections, both. So as sir said, we should go for getting the urine output.
Fagun sir, in brief, if you can discuss about PD prescription, because I think we have brevity of time. So instead of Saloni stating all these, maybe you can tell your practical experience.
Yes. Basically, when I think the judgment regarding doing a PD is basically has to be very quick. So it never depends upon the renal function level. So it doesn't mean that you have a creatinine of 1.5 and you don't do PD, and a creatinine of 5 you want to do PD. I may not do a PD with a creatinine of 5, but I may like to do a PD in creatinine of 1.4. As I said, that it all depends upon the fluid overload and other parameters. That is number one. Number two is this: it is very important that we don't allow the child to go into the fluid overload. Anything about 10 to 15%, even the PD becomes very difficult, because in neonates, actually what happens is that you have this what we say this state the paralytic alias, which and also the severe abdominal wall edema, which causes the abdomen to be very tense. The second very important thing is the thoracic wall edema, which also makes this thorax very tense, and this child always has some fluid overload, that is fluid in the lungs. So they are in a state of very high pressures in the abdomen. At that point of time, if you just try to put a PD and just try to put the fluid inside, the pressures would be so high in the lungs that many a times the child comes up with severe pulmonary hemorrhage caused because of the increased capillary pressures there, and also because the child is having a bleeding tendency. And sometimes the intra-abdominal pressures also rise or shoot so fast or so high that the intestines could just pop up out of the abdomen from the PD site. So to avoid that, it is basically very important that most of the times, or you have to take a quick decision as far as the PD is concerned, and you just try to put it when the child is not get it extremely overloaded. As far as putting a PD is concerned, we do create a reservoir about 20 to 30 ml per kg, maybe around 40 ml per kg if the abdomen is absolutely dry. And once we put the catheter, normally everybody starts with about the cycles about 15 to 20 minutes. Now it again depends upon what you want. Say for example, if I have a severe fluid overload or if I have a severe hyperkalemia, in that instance I may do a 20 minutes dwell time. But if there is severe metabolic acidosis and uremia, the solute clearance will not occur at 20 minutes. It has to be minimum 30 to 40 minutes. So you need to increase your dwell time accordingly. Again, small volumes, if you do, most of the times it is not going to give a good solute clearance or even the potassium clearance. So at least 10 to 20, at least 20 ml per kg is required when you put it inside. gradually, if the urine output is started establishing or you are getting a lot of negative balance, you can just increase the dwell time to about 45 minutes, and that should be fine. So 5 minutes of in time, 45 minutes of dwell time, and 10 minutes of out time. So that is normally completes the 1 hour. And monitoring of the electrolytes, especially the potassium, is very, very important. Practically speaking, what we do is this, that if the potassium is more than 4.5, don't put anything in the PD fluid. If it is between 4 to 4.5, put 1 millicurie per liter. If it is between 3.5 and 4, put 2. If it is between 3 to 3.5, put 3. And if it gets below 3, then you start giving IV also potassium. That is simple as that. And heparin, definitely you put around 0.5 units, that is about 500 units, 0.5 ml in 1 liter of the PD fluid. This is very, very important, because otherwise you will get multiple clots inside of the fibrin clots, etc. So this is as simple as that, and you go monitoring the electrolytes, which depends upon how are they behaving. If they're behaving nicely, you can do once in 12 hours or 24 hours, or else you might need to do, get it done every 6 hourly also.
Preparing a PD prescription, yeah.
And of course,
Preparing a PD prescription is very important,
yes,
because you have to be acquainted with how do you prescribe PD, because nursing staff will only put what you put in the chart. So you have to make a unit chart where it is very clear that which peritoneal dialysis fluid you are using, because there are two kinds which are easily available. You can change the concentration of dextrose also depending on the extent of fluid overload. You have to mention what are the dwell times, when does he have to open, and you have to maintain asepsis, because if you do not maintain, they will definitely land up in peritonitis. As a unit protocol, we send PD fluid cell biochemistry and basically a slide test for checking for pus cells after 24 hours, maybe every second day, depending on the clinical scenario.
correct.
Go ahead, Saloni, go ahead. So Urvi ma'am, so a little bit of it was discussed, but again, because it is a neonate, whether it is term or preterm neonates, do we need to change antibiotic prescription if a child is on peritoneal dialysis?
Not as such. If the baby is fine, we continue with the same antibiotics. But if we are considering that we are going for a peritoneal dialysis, we should keep in mind that if some gram-positive or gram-negative infection can happen. So our choice of drugs may be vancomycin or Genta, which we can add in the fluid also, or we may inject, which usually we do. But unless if we get, as you said, you send the fluid, you check for checking whether there is any growth occurring, or we see in the smear if any gram-positive or gram-negative organism. Accordingly, we should change the antibiotics and keep monitoring the cell count of the PD fluid which we get.
But would the clearance differ, because would dosages differ, Fagun sir? Because we are now doing, in a AKI patient, I was dosing somewhat different, and now I have started peritoneal dialysis. Would the drug wash away with the dialysis fluid?
Yeah, so it all depends upon how is the pharmacokinetics and the pharmacodynamics of the drug. For example, if you have vancomycin, which is never cleared by hemodialysis or peritoneal dialysis, you cannot increase the dose in that patient. So you have to continue with the same dose in the same restriction. But if on the contrary, if some other drug is there, say for example, meropenem, this is excreted by the kidney. So in that instance, you might need to do a full dose of a meropenem. Same thing is for colistin. Say for example, colistin also is excreted by the kidney and is a highly nephrotoxic drug. But once you put the patients on continuous renal replacement therapy, you might need to increase the dose of the colistin. So ultimately, you have to look at your textbooks. It doesn't mean that you can't refer your pharmacokinetics and pharmacodynamics of the drugs. You have to refer it, and then you have to infer what you need to do whenever you are doing a PD or even HD. What drugs, supplemental doses might also be required in some of the instances.
So very important for fellows to note that you have to individualize based on what drug you are giving. Once you start dialysis, those drugs might not be there in adequate concentrations. Go ahead.
And we should keep checking the creatine electrolytes, so we know that whether kidney is improving, we can change it accordingly.
Yeah. So in our case, what had happened is that ventricular tachycardia actually subsided, hyperkalemia subsided after peritoneal dialysis. The child was extubated on room air. The urine output as measured after catheterization on starting PD was around 7 ml per kg per hour. But the hyponatremia was persisting. So this is the child again on room air, comfortable, there is no ventricular tachycardia, perfusion is good, doesn't look that there is any sepsis there. Go ahead. So how do we see that? What are the differentials, Saloni? So quickly, if you can go through what should we think of in a child with hyperkalemia, with hyponatremia, who had weight loss? What are your top differentials in 1 minute?
First differential that we kept in mind was severe dehydration. The points in favor were that clinically, when we received the child was severely dehydrated along with the poor feeding. The point in against were that there was no diarrhea or no vomiting. The child was polyuric and the child had hyponatremia. So it was not explained by the severe dehydration. The second DD that we kept was CAH. Points in favor were that the child had hyponatremia and hypokalemia with metabolic acidosis and shock, but the child had normal external genitalia and there was no hypoglycemia on presentation. As we mentioned, that the RBS was 85 mg per dl. The third differential that we considered was the kidney injury. In the points in favor were that the child had hyponatremia, hypokalemia with metabolic acidosis, and creatinine was elevated, but there was no visible edema. The fourth differential that we kept in mind was RTA, where the child had metabolic acidosis and dehydration, but the hyponatremia and hypokaloridemia was not explained by it. Similarly, the fifth diagnosis was hyperaldosteronism, in which hyponatremia, hypokalemia was there along with metabolic acidosis and polyuria, but there is nothing that we could find there in against. So this is the one differential that we considered as possibility.
And I would like to say if it's CH, it could be a primarily just mineralocorticoid deficiency, which can cause this. So you have got a normal glucose, then you can consider that.
So just quickly, because we have discussed that hypernatremia is common because there is a lot of free water deficit, excess free water being less. So what should be the approach of hyponatremia? I've just summarized here, taken it from every standard textbook. Saran ma'am, or should I go ahead and brief, or maybe you?
No, yes, Akash. This is an excellent diagram and it explains everything. So basically, just the key points are that you just need to see whether the child is hypovolumic, euvolumic, or hypervolumic. If it's a euvolumic, then whether there is a losses from the kidney or losses elsewhere, that is from the GI tract or from the skin losses. So that is basically one set of hyponatremia. Second is euvolemia, and that only 3 DDs will come. Either it is because of hypothyroidism, it is because of SIADH, or it is because of glucocorticoid deficiency. Most of the times, these 3 will be there. And in the case when there is a hypervolemia, either it could be an AKI or a CKD, whatever it is, or it could be nephrotic syndrome, or it could be a CCF, that is a congestive cardiac failure, or it could be because of some chronic liver disease. So these are very, very simple things. But one important thing which I would like to add over here is this, that simply measurement of sodium levels would not work, because many a times you will end up into other conditions like pseudohyponatremia or other conditions like mannitol and hyperglycemia, which can also lead to hyponatremia. So if it is combined, though we don't do very routinely, but if it is combined with a serum osmolality, then most of the times a true hyponatremia will always have a low serum osmolality. If it's a normal serum osmolality or a high serum osmolality, then it is basically a normal sodium level in the blood, but you have to think of other causes. Say, for example, pseudohyponatremia, which is out of scope of discussion over here, and also it could be because of hyperglycemia or use of menthol, etc. Okay.
Go ahead, Saloni. So in this child, we started with excess sodium supplementation because we felt that he is losing sodium from the urine. We started oral fludrocortisone. Go back, Saloni. Go back. So what cleansed the diagnosis was these eyes. You can show the picture. So there are, as you can see, there are white spiky crystals. So what this case was actually of a pseudohypoaldosteronism, systemic variety. So there are two types. One which affects only the kidney, and this is 1B where the sodium is getting excreted from sebaceous glands all over the body. So he was losing salt from all over.
But this carries a very good prognosis actually, because the child will come to you with hyperkalemia and one day he will just conk off.
Yes, you are right, sir. So this is just to tell that both this child had hyponatremia with hyperkalemia, and life-threatening events can happen, and you have to be on the lookout on general examinations if you can find something leading. So we can move to the case 3 now, and I think we have around 5 to 8 minutes left. If we can quickly, briefly summarize case 3 and ask leading questions to Sir and Ma'am, which are very pertinent. Our last case is based on lower urinary tract obstruction, and it is a case of antrenal polyhydramnios where bilateral hydronephrosis is there with thinning of cortex, and the child had to be delivered because of oligohydramnios, almost anhydramnios, at the birth weight of 2.25 kg. Go ahead.
Poly or oligo? Because here it's
Uh,
mentioned hydroamnios.
It is oligo, sir.
Okay.
By mistake, it has been written as poly. So there is
Yes.
antenatal oligohydramnios, and it was almost taken up for anhydramnios. Go ahead. Next slide.
So
So
after baby had bilateral veritable renal swelling, and the baby was catheterized due to the suspicion of PUV due to the poor urine stream and palpable bladder. This is a postnatal.
So I think we can skip this, but we can just show the image that urinary tract dilatation. There is a system where go to previous slide. We grade them based on the dilatation of the calyx, the APD diameter, and based on severity, we see what should be the monitoring. Should we intervene now? Should we subject him to a USG later? And it is a very standard text P1, P2, P3, where P1 is low risk and P2, P3 are high risk. So
in
this
our
was the case where
where the USG showed enlarged right kidney with normal left kidney, bilateral gross hydroureteral nephrosis were there with tortuous ureters, with severe thinning of renal parenchyma along with trabeculated vessels. Echos were also seen in the dilated pelvic calyceal system and ureter. So here they advised us to go for a MCU with the initial creat of 0.67 mg per dl. We go for MCU.
So what should we be looking at in MCU, sir, and when should we do it? You can show the images, Saloni, simultaneously while sir is talking that how do we do this, sir?
Yeah, there is only one indication of doing an MCU immediately after birth. That is basically when you are suspecting an PUL, because PUL is the only urological emergency which requires immediate attention. So there are two things: doing an MCU and doing an USG. So when do you want to do a USG? So in the conditions whenever there is a routine antenatal catheter or we can say antenatal hydronephrosis, we do USG at about 5 to 7 days, because we want that the urine flow should start properly, because otherwise it will underestimate the degree of the AP diameter of the renal pelvis. Okay. But in the condition when we have severe hydronephrosis, either unilateral or bilateral, or when we are suspecting a PU valve, like in this patient, you can easily see that there is a very small capacity, thick trabeculate bladder with a high grade of reflux on one side. I'm not able to make out on which side. And there is definitely a cutoff at the bladder junction of the bladder and also the posterior valve. So basically this is a PU valve, straightforward. And this patient should undergo immediate fulguration. So in this patient, it depends upon what is the age and what is the weight of the patient, what is the size of the phallus. But if more than 2.5 kgs, we can easily go for that. Here, actually, MCU has to be done immediately within first 24 to 48 hours. Put a catheter inside, stabilize creatinine, which is already stabilized. Look for acidosis, look for potassium values, and look for sodium values. If everything is stabilized, on the second, third day, you fulgurate the patient. Don't wait at all.
In this case, what had happened is that the fulguration was not possible because the cystoscope size was such that it was not used.
Done immediately. You can straight away go for diversion, that is the vasicostomy, which is the most easiest thing. And then you can think about other things, whether to go for a diversion higher level, that is basically a loop cystoscopy, etc.
So maybe you can continue, sir. Should I offer prophylactic antibiotics to this child, even though urine routine is normal at this age?
Yes, basically prophylactic antibiotics. There is a lot of debate regarding the use of prophylactic antibiotics nowadays. So even in VUR, many of the centers, even in the Western world, they've stopped using antibiotics, but it has to be individualized. Like in this case, who is having a PUL, especially with a high grade of reflux on one side, which is almost grade 4-5 reflux, definitely a prophylactic antibiotic has to be given, but not more than, or not, the choice should be only between the three antibiotics. One is basically the trimethoprim, second is the nitrofurantoin, and third is your cephalexin. But in the neonate below 3 months, you can use cephalexin. That is it. You cannot use any other things till the child crosses the 3 months of age.
And we should also see if there is any breakthrough UTI, then it may need a long-term, means we need to continue the prophylaxis.
So briefly, what had happened is that we catheterized since we could not find a small cystoscope that was able to fulgurate at this age.
Correct.
So by day 9, this child actually had developed acidosis with loss of bicarb, and he had somewhat polyuria. So Urvi ma'am, what caused this polyuria? We just catheterized, we did nothing.
That's because the antenatally already, like, it's a obstructive uropathy. So already it's been filled with urine. So as soon as we try to catheterize, the urine will come out. And polyuria, it will means we have to monitor this urine output and we have to replace to avoid the severe metabolic acidosis which is happening. And also sudden bladder decompression will also cause hemorrhage also. So both these things we need to consider when we are managing this obstruction.
So as ma'am rightly said that once you relieve this obstruction, there is a post-obstructive diuresis which happens even after fulguration also. So you need to account for that. That happens with catheterization, that happens with fulguration. And as ma'am said, immediate decompression may result in hemorrhagic cystitis, somewhat hemorrhage, and it may cause obstruction of the catheter. Go ahead,
Yes.
Saloni.
On day 10 of postnatal life, the patient developed high-grade fever and the urine routine showed pus cells with creatinine of 1.6. So the baby now is an AKI, and the USG, repeat USG, which was done, showed right and left moderate hydronephrosis with dependent debris. Query pyelonephrosis was kept. Parenchyma was thinned out and increased echogenicity was there, along with a small cortical cyst in the right kidney, suggesting a post-obstructive cystic dysplasia. So in such cases, the question arises is how do we manage UTI or how do we prevent the dangers of AKI and CKD?
Can you just go one slide back? Actually, the sonography. See, the sonography right kidney is mentioning a parenchymal thinning. The parenchymal thickness is just 2 mm, so it is a paper thin parenchyma. There is a raised echogenicity and there are cortical cysts. So this is a dysplastic kidney basically which has occurred. So almost you have lost the left kidney, right kidney. Even the left kidney, the significant dilatation is present and the parenchymal thickness is 4 mm. So whatever function we have is just of the one kidney, and superimpose on that you have an infection now. So this is ought to occur that the child will definitely land up into an AKI. So that's the reason why we want to fulgurate the child as early as possible. We don't want to wait for this thing. But definitely there are some circumstances, as sir mentioned, Akash bhai, that the scope was not available. So the most important thing here is this: that first of all, use of the medications, avoid nephrotoxic medications wherever possible. Try to use the medications which are safe for the kidneys. Number two is minimum handling of the child, especially catheterization and other things, which has to be done under strict aseptic precautions as we are doing any surgery, etc. Putting a catheter also has to be done under strict aseptic precautions, and prevention of the AKI, prevention of the infection is the most important thing which we need to do. These patients, remember that these patients also have poor bladder. So eventually the ultimate outcome of these patients, which I always tell to the parents, is that the ultimate outcome of the kidneys will depend upon how the bladder is going to behave. And looking to your slides, which you've shown, bladder is very small and it is highly trabeculated. So this patient is not going to have a good outcome later on also. This patient is going to land up into a CKD in the long run. You have to be ready for this patient going into a CKD. You need to go for a bladder augmentation later on, and you will need to go for a transplantation later on. So basically you can just need to foresee what are the things which are going to happen depending upon all these things.
So we decided to do a urinary diversion because of pyelonephrosis on the right side at that time. Subsequently, this child was discharged after this UTI settled, and thereafter fulguration was done at a later age.
Correct.
So I think we'll end the discussion somewhat with the remarks on when should we do these scans, sir. In any case of lower urinary tract obstruction or PUJ, when we see anterior hydronephrosis. So what are these scans? There are 3 scans that we commonly look at: EC, DTP, and DMSA. And I think this should be the last question because I think we are running out of time. Gunjana, is it? Sir, please go ahead. I think
Okay,
Gunjana is
for
on.
So I just briefly, so basically, DMS is dimer captosuccinic acid scan. This is done to see whether the child is having any scarring. So it takes into consideration the cortical function of the kidney. Normally, we try to see how the kidneys are there are scars or not, or whether the child is, or the kidneys are dysplastic. So DMS scan after an episode of UTI has to be done minimum after 3 months. The best time is 6 months after last episode of the UTI. TTPA is the dimer captos. I'm sorry, I just forgot the full name of this, pentoacetic acid some scan, but basically DTPA scan is for the excretory function of the kidneys. Normally in the children below 1 year of the age, we try to do an EC scan because it gives a good idea about not only the cortical function, but also about the dynamic function of the kidneys. EC scan can be done a little bit earlier also. So normally at 6 weeks of age, you can do an EC scan, especially when you're suspecting an obstructive uropathy like a PUG obstruction. While in the older children, for example, about 1 year of age, you can do a DTPA scan because it's a little bit more cheaper, and you can do it for the obstructive uropathy, that is like PUG obstruction, etc. So in this patient, if the last episode of UTI was this one, then after 3 months or 6 months of the age, preferably, because even DMS scan in the newborns or in the neonates or in the infants is more accurate when you do it at 6 months of the age. Okay.
Go ahead, Saloni. I think this child is in our follow-up now. Again, as sir said, one kidney is functioning well. The other kidney, of course, is minimally functioning. Reasonably doing well, but as sir said, that incidence of CKD will be in almost to the tune of 30% to 40%. I guess Jatin sir or Gunjana ma'am, are you here? I think we should end at this case because we have run out of time. Sir,
Yeah, I think it can still go on because the discussion
okay.
is going very nicely, but we should allow some time for the questions and answers from the
Sure.
if they want to ask. Right now, there are no questions and answers, but if all the participants wants to answer, they can write a question in the question box.
Please write your questions.
Meanwhile, if I can ask a couple of questions, sir.
Sir.
Pagul sir, I have a practical question. If we often end up with babies who have got a NEC and they get a renal failure. Now, if it comes to the point where we need to consider peritoneal dialysis, is it very appropriate to perform in such a tender abdomen, or what is your take on that?
Catch-22 situation it is. Basically, you can't do anything. You are helpless over this point of time. So here the pediatric surgeon has to pop in, because what he will do is this, that he will open the abdomen, do a nephrotomy, do some, what we say, stomy or something, and simultaneously he can also put a catheter inside, a simple drainage catheter, which can be used later on for the, what we say, for the peritoneal dialysis. But as I told, that in these patients, what you can do is this, that one practical thing which we just recently did, because as you mentioned, this was the same case that the child was having NEC. The child was in shock on multiple inotropes, was on adrenaline as well as non-adrenaline. So what we did was, in this patient, we started with a low dose of Lasix, and initially the child was on adrenaline. The child was not on NORAD actually, but the mean pressures were keeping always very low, above below 30 and above below 25. So what I would always prefer is that the mean pressure should be above 35, because this will help in the perfusion of the kidneys. And so we just added a touch of the NORAD, about 0.05 mics per kg per minute, which maintained our diastolic pressures in a good range, and the mean pressures above 35-40. Along with that, we started with a low dose dopamine, not for the cardiac effect, but just for the renal perfusion impact at about 3 to 4 mics per kg. And once the BP improved, we also added a low dose of Lasix. And just believe me, after 24 hours, the child was polyuric. And even the renal functions improved over the period of 3 to 5 days, probably because the infection, etc., was under control. So this is definitely a catch 22 situation. In severe NEC stage 3, you will not be able to put a catheter inside. But as I told you, if it is a demand of the time, then the surgeons can chip in over here and can do a stomy as well as put a catheter to salvage the child if it's possible.
In fact, sir, our next case, if you can show the image, Saloni, for case 4, meanwhile we are waiting for questions. So this child was a similar child as Jatin sir said, but this child was a term child. Succumbed to parental asphyxia in a peripheral hospital. You have the picture, Saloni, with you. Okay? So after he had seizures, he required respiratory support. As you can see, this abdomen actually started turning black.
Yes.
And there was abdominal wall edema. And
Correct.
then he went into renal failure. He was on inotropes.
Okay.
So as I said, this is a very practical situation, that what do you do? So at times, the child had DIC as well, low platelets, pitiability prolonged. You have to give FFP, you have to give blood products. It will lead to more hyperkalemia because you are giving the additives have some sort of potassium. The blood RBCs have potassium. So you can then actually get hung up in a loop. And as we know that hemodialysis or CRRT doing in neonates is a challenge because of the priming volumes and the cost of the machine, as you can say. But again, Sir Pagun sir, please, if you can chip in.
Akash, but the CRRT basically it is not possible in the neonates, because CRRT you can use, it can be used depending upon the circuit which is available. That is, the HF20 is the smallest circuit which is used, and this can be used only for the child more than 4 or 4.5 kgs. There are machines nowadays which are developed, like the Nidus machine and the other, yes. So, but basically, even in the Western world, in the most developed Western world, they are not available. So it is out of question. So for us, we don't have anything. Hemodialysis is again out of question for this 1.5 to 2.5 kg child. It is not possible. We'll just land up with the in a drastic and in a bad situation, and in a non-futile situation. So basically, in this point of time, you just have to keep your fingers crossed. Or as I told you, that the surgeons could chip in and they could just only open up the abdomen, at least deflate the intestines, etc., and they can just put a catheter. This is what our surgeon does, and he puts a catheter. We don't start a PD in that instance also, but we can just wait. As the clinical condition might improve, we can use that catheter for a PD in case if it is improves.
You can move ahead, Saloni, in the case. What questions do we have? Fluid management in oliguria, as said, we had discussed dopamine, I guess. Blood
Yes,
products,
yes.
again, we have discussed that neonatal AKI blood products are a little tricky. And there are no options. We'll have to give blood products. Saloni, next. Fluid restriction versus normal fluids in sepsis would be one, because even in term neonates or late preterm neonates, we have a lot of sepsis. They have AKI. Again, we had discussed this in cases of Elgans. Should I be worried about third spacing? And if there is third spacing, how can I assess the intravascular volume status and whether my kidneys are getting perfused? Because generally, what general people tend to mistake is that for third spacing, they can restrict fluids. They will then say that the child is landing up in AKI and I need to restrict fluids. And they might actually do more harm in that case. So how do I actually choose whether I should give restricted fluids, whether I should give normal fluids, or the intravascular volume is low because of third spacing, then I should give more fluids?
We need to check we have to check the electrolytes, how the sodium, potassium, the weight of the baby, and obviously the blood pressures of the child, the vitals, what we are seeing. So fluid, what we are giving in a sepsis, already there is a shock like, or if it is happening, like the perfusion to the tissues is already hampered because of the capillary leakage. So if we start restricting, it may further damage. So we need to give the normal fluids in a septic child. We may not overload if they are going. We need to give the inotropes, and along with that, we need to see the cardiac output, doing the perfusion of the organs, the renal perfusion, as well as whatever is the cardiac output, the effective output of the heart. So by echo, we should be regularly doing in such babies, so we know the perfusion and the pressures of the vessels.
I think the most important thing, I think the most important thing here is this, that we do a functional echo, and that's functional echo will tell us a lot of things regarding the fluid. So if your IVC is empty, definitely you need to give fluids. And what we do here is this, we also check upon the albumin. If the albumin is low, we give very low dose albumin continuously along with the Lasix, and that will definitely help. If the child is overloaded, if your IVC is stuck up and full, then that is the case when you need to restrict the fluids. And if the pressures are good, then you can liberally use your diuretics, and if they are not responding, then ultimately eventually you have to go for a renal replacement.
So it's a tricky situation where one answer will not justify all
Yes,
things.
definitely.
It is not a simple
It has to be individualized.
It has to be individualized.
Again, between albumin, do you advise 5%, 20%? Is there any guidance for that?
See, 5% will always require more volume. So in neonates, we require less volume to be given, because we are in dearth of giving the fluids. We have less amount of fluids which needs to be given. So I will definitely try to give 20%, but we give it very slowly over 24 hours. Say, for example, 0.5 to 1 gram per kg over 24 hours along with Lasix. So this is what we practice, so that the child, but only in the children who are having an IVC which is empty and the urine output is fair enough. If your urine output is not fair enough, then sometimes you can land up with severe, pulmonary flooding of this fluid.
It will cause a problem, in fact.
Correct. So it is a very tricky situation. It is a very tricky situation, but only thing in inverted commas, if the urine output is fair enough.
Pediatric intensivists tend to use it very liberally. Again, neonatologists being a very conservative branch, we tend to
even
use
now.
less.
So even now in the pediatric intensive case, basically in the care, they say that less is more. So don't overload anything.
And I guess there is no much evidence if you look at evidence-based medicine. What is the evidence as used in neonates?
No, there is no evidence. This is just some practical tips which we use, because sometimes we are stuck up and we don't have any answer. So we just have to sometimes go away from our regular practice and try to, use the things which could really help. And we have seen the good response in these patients, especially as I told you, if the urine output is good. So definitely it works very nicely. The edema reduces, the child undergoes good diuresis, and definitely the overall morbidity becomes very low.
I think I will go and ask one question to Akash. You use in the first case, you use about 220 or 240 ml per kilo per day fluid. So it just a lot of audience might get benefit. What is the upper limit you can use in such preterm babies?
In Elgan, sir?
Sorry?
In extremely low gestation age newborn, sir.
Yeah.
So first is that so if we can prevent insensible water loss, that is foremost, because giving excess fluids will come with its own complications. But if there is sensible water loss, say urine, the child is losing free water and sodium, natriuresis, potassium from the urine. So our general policy is that any urine more than 4 ml per kg per hour, say if it is 8, 9, whatever it is, we replace that fluid. And we again we look at sodiums, we look at weights, we look at our focus, we look at the echoes, we look at PDAs, we look at the adequacy of the whole adequacy of intravascular volume status. We have given around 220 to 240 ml per kg per day, sir, in elegance, and it depends on the individual situations. Majority of times it has worked, sir. But again, prevention is always better than cure. But these are sensible losses rather than insensible losses, because the child is losing from urine here, sir.
Many a times it happens that the urine output in this very extremely low birth weight babies go up to 10 to 12 ml per kg per hour. So basically at that point of time, what you need to do is this, that forget about how much amount, 220 or 240. Just calculate the insensible loss plus urine output and just replace the urine output which is coming in the previous hour. So that is now sometimes what we prefer. So you just calculate the urine output in the last 4 to 6 hours and give it in the next 6 hours over and above the insensible losses, which should be also not 400 ml per meter square, but up to 500 to 600 ml per meter square.
And replacement should not be over 24 hours, because
Yes,
as I
yes.
said, every 6 hours urine
Every 4
output
to
has to be
6
checked.
hours.
Otherwise, it'll overload the intravascular volume.
Definitely, yes.
I think somebody has asked in the question and answer, which fluid to use for replacement for polyuria?
She
We
mentioned
use
it's half,
N/2.
yes, half NS.
And with potassium, if there are no concerns of hyperkalemia AKI, you have to supplement potassium also. 1:100 ml as a
It will
standard.
be like tailored for depending upon your
Yes, sir. Yes, sir.
and sugar as well. I guess there are no more questions, so it's already 10 o'clock, so we should we can close the session.
Yes.
And I think I would like to thank all the faculties. Saloni, you did very well. Dr. Akash, you were very good at moderating. I think you have given nice synopsis of what is the challenges we encounter in neonatology, fluid electrolytes, including decision for PD. And I would like to thank Dr. Fargun sir and Urvi ma'am for enlightening us on this very challenging topic of AKI. I think we will end the session here. Thank you very much, guys. Thank you.
Yeah, thank you.
Thank you.
Yeah, thank you very much for the opportunity. Thank you very much.
Thank you again. Good night.
Good night. Good night.